Thank you, everybody, for joining us for the DSRIP 101 presentation. It's presented by the CHS DSRIP Project Management Office, and it's regarding the New York Delivery System Reform Incentive Payment Program, otherwise known as DSRIP. So today I want to take you guys through the basics of DSRIP. We're going to discuss the concepts and goals of DSRIP. We're going to go over the projects that Catholic Health Services of Long Island Hub has selected in both of its organizations that it's participating in. We'll talk a little bit about funding, and we'll leave off with sort of future steps on how we're going to progress implementation at the CHS Hub level. So to start out with, I want to go over some basics of the DSRIP program. It is a 5-year program, and it officially started April 1st of this year, 2015. It is a Medicaid reform program that is going to transform and improve healthcare delivery throughout the state, and it has a couple of overarching goals. The biggest overarching goal is reduce avoidable hospital use by 25% over the next 5 years, and I want to emphasize the word avoidable. So it's not that we're avoiding all hospital use. I also want to point out that because this is a Medicaid initiative, we're really talking about focusing on safety net providers. And there is a definition of safety net providers that the state has provided. Essentially, it's 35% of your outpatient visits. If 35% of your outpatient visits or more are Medicaid, then you're considered a safety net provider. For the hospitals, if 30% or more of your inpatient discharges are from Medicaid, then you are considered a safety net provider. And this program is really to shore up and keep viable those safety net providers that serve so many of the Medicaid recipients. Also, what you'll hear a lot when you start getting involved in DSRIP is this concept from volume to value. So right now we're in a fee-for-service world. We are over-testing. We don't necessarily incentivize outcomes. We incentivize, the number of tests we do. And the goal from the state is to be about 90% value-based payment by the end of these 5 years. So we want to get rid of fee-for-service as much as possible and end up in an incentive structure for providers where avoidable hospital use is rewarded and better outcomes are rewarded. And that's what we mean when we say volume to value. So some of the transformation goals for DSRIP, they really revolve around population health management. So we will be undergoing a lot of exercises to overlay care management activities, to stratify our populations and target high-risk patients, keep them out of the emergency department. We also, because of this population, we are paying attention to culturally and linguistically appropriate care. And this is really going to overlay almost all of the project work that we do. We want to make sure that we are speaking the same language as these patients. We also want to be sensitive to their cultures. We want to understand their health literacy and help improve it. So things of that nature. Also, there's a huge emphasis on community-based organizations. We aren't just going to be health providers providing services to this population. There are so many people that need to utilize other support services in the communities. And really, by working with those community-based organizations together, we're going to be able to do more of a holistic approach to serving the needs of the Medicaid population. I already touched a bit on performance-based payments, and although this project is only 5 years long, the goal at the end of it is that the delivery system will have transformed and be financially sustainable going into the future. So, performing provider systems, or otherwise known as a PPS. So within the state, there are actually 25 PPSs. Catholic Health Services is involved in 2. One is the Nassau Queens PPS, and one is the Suffolk Care Collaborative PPS, and we'll get into a little bit more about the structure of those. But basically, it's a very large provider network with providers on the continuum of care, so clinics, primary care providers and specialists, behavioral health sites, hospitals, nursing homes, home care, etc. And it's also important to realize that when we talk about who we are serving, the way that we sort of organize the membership into these PPSs, or the Medicaid lives, as we say, is that a Medicaid member, through a very complicated algorithm that the state put forth, is assigned to or attributed to one provider, which is then connected to a PPS. So the network makeup I did allude to. This is sort of a representation of the continuum of care. The IDS in the middle stands for Integrated Delivery System, which we will get into with our first project. And here's a slide on the structure of the PPSs that I mentioned. So on the left, you have the Nassau Queens PPS. You basically, North Shore LIJ, Nassau University Medical Center, and Catholic Health Services of Long Island all started out in Nassau County actually as their own PPS. We applied to be our own PPSs. And back in last summer, we one of the first major initiatives of becoming a PPS was to do a community needs assessment. And these community needs assessments were very robust and very thorough, and all 3 institutions said, why are we going to spend a lot of time and money doing our own assessments of the same geography? Let's work together, and let's do one assessment for the entire county of Nassau. And with North Shore LIJ, LIJ being on the border of Queens, and with Catholic Health Services, we have a very strong partnership with St. John's Episcopal in this. We also expanded the territory to Eastern Queens, and we performed one community needs assessment together. Well, through that process, we felt that we were probably going to make a better impact if we continued to work together. In addition, the state dangled a couple of carrots in front of us to incentivize us further to become one PPS. And so in the fall, early winter of 2014, we officially became one PPS. And we have a governance structure where technically NUMIC is the lead. They are a public hospital system, and that brings a couple of benefits to the PPS as a whole. So technically they're the lead, but the governance structure is such where it's really collaborative in nature between the 3 institutions. You will see listed below the institutions, there are a number of hospitals participating. Some are safety nets, some are not. You will see community-based organizations affiliated with each what we like to call hubs. So each health system really is called a hub. We have physicians that are affiliated, again, the full continuum of care. Now, CHS is also participating in what is called the Suffolk Care Collaborative, and that lead truly is Stony Brook. They were always going to be the lead, even though there was always the intent to have a strong partnership with Catholic Health Services and North Shore LIJ. So we do participate with them sort of on a high level, making decisions with them and working with their project management office to accomplish the goals of DSRIP. And it's similar in nature. We all sort of have partners and providers within our hubs that we will be working with to actually implement these projects, which we will get into very shortly. So the state provided a list of somewhere between 40 and 45 projects that they wanted each PPS to to choose from, and essentially what the projects do is operationalize the program, the DSRIP program. So you could choose up to 10 projects originally. You had to do a little from column A, a little from column B, but essentially your community needs assessment, the one that was performed during that summer, plus a bunch of stakeholder input, leadership input from the health systems, it all came together, and so each PPS picked up to 10 projects. Well, actually, at some point before we had to put in our application, there was an additional 11th project that became available, and the public hospitals actually had a right of first refusal to participate in this 11th project, which is one of the benefits of NUMIC being the lead entity, and Stony Brook is already the lead entity and also a public hospital. So this 11th project, also called 2DI, also called the Uninsured Project. It has many names that you might hear in the future, but it is really targeting the uninsured and the low and non-Medicaid utilizers. And basically, low and non-utilizers refer to people who are enrolled in Medicaid and maybe assigned a PCP, but they haven't shown up in the system. No claim was dropped. They have not been activated. Very similarly, a low utilizer might be somebody who shows up at the ED a couple of times a year, but it's clear that they don't have a consistent source of primary care or care. And so this project really is to activate and get them access to the care on a regular basis. So I'm going to talk about the CHS projects that were chosen. You will see a little color coding going on here. We have a total of 15 projects. The 7 in the middle in the lavender represent the projects that are going on in both Nassau Queens and Suffolk PPSs. The pink on top, there are 4 projects which are only going on in Suffolk. And the 4 in the light blue on the bottom are 4 projects that are only going on in Nassau Queens. So while I'm sure everyone in the CHS project management office would love all of them to be in lavender, it is actually quite manageable. A lot of these projects are similar in nature to each other, and we feel that as a CHS hub as a whole, we will be working and bringing like people together to work across both PPSs actually as much as possible to work on these projects. So now I'm going to detail, I'm going to very briefly detail what each of these projects are about, and I hope to go relatively quickly. So the first project is to create an integrated delivery system. So I'm going to always preface it with the number. There's a naming convention the state put forth, and while we in DSRIP, those of us who have been living and breathing DSRIP for the last year plus probably know our projects by heart. I appreciate that that those listening will not and should not, but I will probably mention it once or twice. So 2AI, created an integrated delivery system. This is what we kind of call the Big Kahuna project. This outlines some of the very large, widespread business requirements that sort of sprinkle throughout the rest of the DSRIP projects. So, for example, every single provider in your network is expected to participate in this integrated delivery system project. I don't know exactly, but in Nassau Queens, I think we have over 6,000 partners, and in Suffolk, I believe there's something like 4,500 partners. CHS Hub has probably close to 1,000 in each of those PPSs. So there's also a huge IT component that's sprinkled throughout 2AI. So they want active sharing of information between providers. We're talking secure messaging. We're talking access to medical records, alerts if somebody from one hub or another, or frankly another PPS even shows up into an emergency room outside of that geographic area. We want to make sure that the providers that generally care for that patient are alerted. Another huge heavy lift is ensuring that all PCPs, primary care providers, reach Level 3 2014 Patient-Centered Medical Home Recognition, and this has to be done by the end of the 3rd year of the program. For those that aren't familiar with PCMH model, it's a model of care centered around a primary care practice where there's a heavy, heavy lift and layer of care coordination for patients. There is, you make sure that they are in for their preventative services, that they connect to their specialists, including behavioral health needs, lots of screenings, and making sure that the patient is provided, it's usually extended access and hours, and we want the patient to feel really like it's their home, that they have a place where they can call, they feel safe, and we're taking care of them very proactively. So this is a very large and very difficult initiative that sort of resides in this 2AI project, the Integrated Delivery System project, but will be, you'll see it's going to come up in a bunch of other projects as well. And finally, the last really big heavy lift that resides in this project is working with the managed care organizations to initiate and then solidify value-based payment arrangements. Okay, so I'm going in sort of sequential order here, not in the order of the chart, and so the next one in line is 2B2, development of co-located primary care services in the emergency department. So basically, this is only occurring in Nassau Queens, and within the CHS hub, Mercy and St. John's will be participating. Essentially, what needs to happen is on the same campus as the hospital, you need to build a PCMH facility. And when a patient shows up in the emergency department that is not requiring emergency services, generally what we think of today as maybe a fast track or an express care patient, they will be rerouted to the patient-centered medical home to complete their care. Now, we actually just had a little revision with the state, and we have another layer to this project. And so if it's not practical to be routing somebody on the same day of the service to the PCMH, then there is an opportunity, and a goal of the project is now to connect them back to their PCP. If they don't have a PCP, connect them through your PCMH and ensure that they have a follow-up visit or a preventative care visit within a month. So, we have to be conscious of EMTALA standards if we're going to be transferring patients from the ED to the co-located PCMH. Again, there's a large care navigation component because we need to make sure these people that are rerouted are taken care of, that they're connected to a PCP or rerouted back to their existing PCP, that if we make an appointment for them, that they have follow-up. For those that aren't connected at all to a PCP, there's a process there to assign them to a PCP. So there's a lot of care coordination going on. And we also will be spreading the message through community-based organizations in the community to help us educate patients on alternatives to the ED. There are billing implications for rerouting from the ED to a PCMH, so we'll be working on those implications as well to make sure we drop an office code. Okay, 2B4, care transitions intervention model to reduce 30-day readmissions for chronic health conditions. So essentially, this is directed at Medicaid patients that are in the hospital with a focus on those with high risk for preventable readmission conditions, chronic health conditions, and what we want to see happen is they have discharge planning early. It's comprehensive. We educate the patients on what is going to happen next. And then once they leave the hospital, there is a proactive time period of about 30 days where we make sure that they get to the next care setting that they need to be. So we'll be working with home care agencies. We'll be working a lot with the PCPs to make sure that they're making follow-up and they actually attend those follow-up appointments. There was a high degree of population health management overlay. There's a high degree of information sharing necessary to make sure that we do what we call warm transfers or warm handoffs to the downstream provider to ensure that somebody is looking over these patients and they're not coming back to the hospital. Next project is 2B7. It's implementing the INTERACT project, and this is really a transfer avoidance program for nursing homes. The INTERACT program, it's a pretty prescriptive program. It's a toolkit. It has tools, and it has care pathways, and all of these things that are really centered on observing a patient in the nursing home, doing early identification of any issues, and trying to stem them before the need to transfer them over to the hospital. And I apologize, the 2B7 is being done, the INTERACT program is being done in both Nassau Queens and Suffolk PPSs. Now, the 2B9 implementation of observational programs in hospitals is only being done in Suffolk. I'd like to point out both the transitions of care project, the prior one, and this one. A lot of these initiatives are going on in our hospitals as we speak. We're all trying to reduce readmissions, especially avoidable readmissions. A lot of hospitals are implementing observational programs. So this is really just building on what's already going on in our hospitals, making it more robust, making it more comprehensive. So at least with the Catholic Health Services hospitals, we do have observation programs in all of our hospitals, and we will just be working on them more to align, make sure we fulfill all the additional DSRIP requirements, and so yeah, so it'll be just an expansion of what we're already doing. So moving on, we are into one of the first behavioral health projects, 3AI, integration of primary care and behavioral health. There is, I probably don't need to tell you, but individuals with behavioral health issues really spans through all of the projects. As we probably know, behavioral health patients, especially patients with severe mental illness, are frequent flyers to our ED, and the network available to them is not necessarily, it's pretty fragmented, it's not very comprehensive, and it's confusing. So there are a number of projects that are focused on that population. This is one of them. Typically, so there's three models to this project. One is co-locating behavioral health services at a primary care site. So the primary care site needs to become a PCMH, a patient-centered medical home, and then the idea is to screen every patient there with some sort of anxiety or depression, some sort of nationally recognized screening tool. This is really for early identification, more identification, et cetera. And then the idea is also to have some sort of behavioral health practitioner in the building that can either immediately respond to those screenings if they screen positive for something, or make sure that they connect to the appropriate, behavioral health clinic or substance abuse clinic, et cetera, if it's found necessary. The other model that we're doing, so in Nassau Queens, we are participating in models 1 and 2, and in Suffolk, we're also doing this project, and we're participating in 1, 2, and 3. So the second model is that we co-locate primary care services at behavioral health sites. So it's really just reverse. The focus is people who have serious mental illness oftentimes do not get proper medical care because they are so consumed with their behavioral health needs. So this makes a convenient option for them to sort of get both done. And then finally, there's the third model of impact, and it's an integration model where you're improving mood, providing access to collaborative treatment, and it's sort of a blended model. Another behavioral health project, 3AII. It's Behavioral Health Community Crisis Stabilization Services. We are only doing this in the Nassau Queens PPS. I think this might be one of the, if not the most challenging project that we are up against, and I also think it has the potential to make the most difference. As I mentioned before, and as many of you know, we have a very fragmented and confusing behavioral health network, especially for people in crisis. Oftentimes when there's a behavioral health crisis, people end up in the emergency room. It's probably the last place where they need to be or should be. Oftentimes it exacerbates their condition. It's not really a respite for cooling down. So the idea here is to create a network of alternatives to the ED. And the PPS has come up with sort of a six-pronged approach. So there will be a psychiatric crisis-oriented unit developed within our PPS. There are a few different locations that we're looking at that for right now. An expansion of observation units for behavioral health. And I would say that all of the remaining four items, mobile crisis teams, crisis hotline, walk-in crisis clinics, and respite housing options, they all exist right now. But the idea here is to really scale them up, increase access to them, increase coordination between them, increase awareness to community-based organizations and other healthcare providers about their existence and how to access them. Okay, so interestingly, any project that starts with the number 4, and in this case it's 4AII, prevent substance abuse and other mental emotional disorders, the domain, what they call domain 4 projects, are really aligned with the state prevention agenda items and are intended to be companion projects to the hospital's community service plans. So unlike some of the other the projects that start with the number 2 or 3, there is more of a population health approach. There's less of an emphasis on reporting on metrics and outcomes to the state, and it's more about building infrastructure and capacity within the communities. So this really is to implement evidence-based practices to identify underage drinking, substance abuse, to prevent underage drinking and substance abuse. And really focus more on other strategies potentially. Smoking cessation is part of this, particularly with people with mental illness. 4AII, strengthen mental health and substance abuse infrastructure across the systems. Again, there's this program called, or a term called mental emotional behavioral partnership, mental emotional and behavioral programs we call it MEB, and we want to focus on health promotion and prevention. Again, there's a large component of culturally and linguistically appropriate care, and doing a lot of collaborative care with primary care on these mental and emotional and behavioral issues. And so there's a lot of collaboration between primary care and behavioral health, again, and as we saw in Project 3AI, or the integration project. There we go. Sorry, wasn't advancing the slide. Next slide is 3BI, evidence-based strategies for disease management in high-risk affected populations, adult populations specifically, and the focus here is on cardiovascular issues. So there is, again, a huge PCP participation in this project, where we will be leveraging that PCMH requirement. We will be deploying evidence-based cardiovascular strategies to coordinate care for those, particularly with hypertension. And this project will be going on in Nassau, Queens, and Suffolk. And there's a large emphasis on sort of self-management goals, medication adherence, lifestyle changes, and things of that nature. Oh, there we go. 3CI. It's essentially, again, in both PPSs, it's essentially the same project, but for those with diabetes. So again, we're going to look at communities. You'll notice the hotspotting strategies using data. So we're going to find communities that have a high prevalence of diabetes. We're going to implement the same strategies. We're going to pick evidence-based protocols to disseminate on how and when to treat patients. We want to do a lot of preventative care. We want to do medication management and really do a lot of self-management goals and education. Okay, 3DII is the expansion of asthma home-based self-management programs in community settings. This is only going on in the Suffolk PPS, and essentially it's a home-based program where you go to somebody's home and you find, you do full assessments of triggers and you link clients to help them do the trigger reduction interventions. You do asthma management, self-management guidelines, and do a lot of education. And it's pretty unique because you're going into the home and you're doing a lot of one-on-one care and sort of pilot programs that we've seen doing this. Really, they do an average of 4 or 5 visits per family. And sort of, we're rounding out our sort of disease management projects here. So 4BI, promote tobacco use cessation. This is only in Nassau Queens PPS. There's nothing really new here. We are really trying to leverage existing activities that have gone on over the last decade or so to reduce tobacco use. And we're finding communities where we need more intervention. So, for example, in the Flushing area and the Rockaways where we're participating in Eastern Queens, there are some of the highest prevalence of smoking occurring in those communities. So there's still a lot of work to be done in pockets out there. 4BII, increase access to high-quality chronic disease preventative care and management in both clinical and community settings. So there is an emphasis here on enhancing reimbursement models to deliver high-quality chronic disease prevention and management services. You will help, again, patients navigate the network of preventative services in the community. And again, as I mentioned, this is supposed to correspond to prevention agenda goals. Okay, and this is the famous 11th project, 2DI, the uninsured project, the one with many names, and it's the implementation of patient activation activities to engage, educate, and integrate the uninsured and low non-utilizing Medicaid populations into community-based care. That's quite a mouthful. But basically, there's this tool called the Patient Activation Measurement Tool, called otherwise known as PAM. It's a survey. I believe it's 13 questions long. You administer it to people, and then essentially they're assigned or stratified into activation levels. I believe it's 1 through 4, essentially 1 being not very active, engaged in their healthcare, 4 being very engaged. And just a note, this is not a tool that is specifically designed for like a low socioeconomic population. You could administer this tool to, I think they use the example of a Fortune 500 CEO, but what it does is this project incentivizes us to really work with community-based organizations who will see a lot of patients, or rather, I should say, potential patients, because they are getting food stamps, or they need help navigating other, clothing, housing, WIC, other types of services out there that oftentimes this population needs more than even health care. And these community-based organizations will help us find those that aren't coming through and into our systems. So there'll be a high prevalence of community-based organizations brought into this project, people trained to administer this survey, also people in our emergency departments, and this project is going on in both PPSs, as I might have mentioned before. So this is really a very, very large project that expands through kind of every nook and cranny of our communities and will be involving a huge array of providers to help identify and then connect these individuals with care. Okay, so we have now gone through all of the projects, and I know that was quite a mouthful that I just said, but I did want to give you a brief overview of all the projects. This slide is really interesting. It's about the common DSRIP project elements. We have these things called work streams that the state has also introduced into DSRIP, and work streams really correspond a lot to this slide. If you think vertically about the projects going down, work streams represent sort of the horizontal business requirements that may run through all or most of the projects. Things like IT, workforce transformation, finance and governance. And then after that, a lot of things that are on this slide would apply. So, you know, we've talked already about PCMH. I think you could see that it affects a lot of the projects. So does managed care organization collaboration. There will be a lot of IT infrastructure built at all of these organizations to create this integrated delivery system, including population health protocols and an EHR system with this real-time notification when somebody pops into an ED. We've talked a lot about community-based organizations, how we're all sort of working together to complement each other and to fill up this network and help patients navigate the network of services that is available to them. There's a large emphasis on behavioral health intervention and services. And again, you know, especially with this population, there is attention to cultural and linguistic care and health literacy needs and education and things of that nature. You can go ahead. So I wanted to take just a minute to talk about the DSRIP funding. So while I like the emphasis to be on the programmatic work and talking about what we really have to do and things that we want, the goals that we want to accomplish, we can't really do it unless we have money to do it. And in addition, the state has set this program up where it really is sort of, we do have a pot of money that's coming to us, but it is based on incentive structures. So we need to meet certain goals and objectives, improve outcomes, et cetera, to get the full amount that that is possible. So there was a project valuation process that went through the state. We had an application that went in right around the end of 2014, and it was evaluated by an independent assessor. Different projects had different totals, so the funding that comes to us is actually on a per project basis. At first, the incentive structure is to pay for reporting. So we have all these goals and milestones and metrics and outcomes that we are working toward, and we need to be reporting progress toward meeting them. Eventually, especially toward like when we split from year 2 to DSRIP year 3, then they're saying, all right, well, now we're going to pay you based on your performance. So we actually have to close some gaps. There are the state set out targets for a number of metrics, and we have baselines that we need to close the gap on every year to reach the target. We need to fulfill a number of those sort of bullet point requirements that you saw in the previous slides for the projects. Those are actually milestones, and we have to do that. We have to have all of our PCPs up on patient-centered medical home by the end of year 3. All of these have implications, performance implications that if we don't meet, then we won't necessarily or we will not get the full amount that we could in funding. And it's very interesting to remember that even though we're divided into hubs, and we, at CHS and within our hub, we will be responsible for the providers in our hub and the performance of our hub. But if the PPS as a whole, and even the state as a whole, doesn't meet some of these metrics and improvements, then we all we all fail together. We succeed together, we fail together. So if CHS does terribly on an outcome, but NUMIC does exceptionally well, we might be saved because of the performance of NUMIC. But the reverse case is true as well. So we all want to be very diligent and cognizant of the fact that we need to work together to achieve our milestones and our metrics and our outcomes. Okay. Just a quick snapshot of the lives and the money coming, or available rather, in the two PPSs. So on the top we have Nassau Queens PPS. We have potentially about $535 million coming over the next 5 years. Some of it is, again, going to be sort of guaranteed and pay for, as long as we're reporting our progress, we're going to get it. And a lot of it is actually at risk if we do not meet our milestones and our goals and our objectives. And also remember, this is a PPS-wide distribution, so it hasn't been determined at this point in time how much the CHS hub is eligible for. I will make a very interesting point, which a lot of you might not be aware of, but our partnership with St. John's brings an incredible amount to the Nassau Queens table for our hub. We are taking an educated guess that approximately 2/3 of the attribution that we receive into our hub, and therefore 2/3 of the money, will probably go towards St. John's and activities in the Rockaways. St. John's is what we've been calling the poster child for DSRIP. They have something like 90% inpatient Medicaid discharges, and I want to say 70s or 80s for outpatient Medicaid visits. So that is well above the threshold, and I think that I've heard they're maybe second or so in the state in their percentages. So a lot of this is going to them. You can see that we have over 1 million people that are attributed to the Nassau Queens PPS. About 645,000 of them are Medicaid enrollees, and about 385,000 are uninsured. And actually, what's interesting is we have, we have every single person in Nassau County is attributed to us. We're the only PPS that is operating in Nassau County, and so every Medicaid life and every uninsured person, and I think the uninsured was based on census data, was attributed to Nassau. But in Queens, we have multiple PPSs, and HHC is another public hospital system that is participating, and they have a presence in Queens. So those uninsured total, that uninsured total is actually split. There are a tremendous number of uninsured in Queens, and we have, I don't remember if it's maybe 40 or 50% of them, and HHC has the other. So we are collaborating actually across PPSs on certain projects. In Suffolk, we have close to $300 million available over the next 5 years. Because it's just one county, we don't have the breakout between Nassau and Queens, but we do have approximately 270,000 Medicaid enrollees and about 169,000 uninsured. So we have about 438,000 total Medicaid attributed members for the Suffolk County PPS. And just so you understand, there are sort of categories that we're allowed to use this funding for. So I think very straightforwardly, the main way that we're going to spend the money is to cover project implementation costs. So that includes covering costs for the project management office, and I believe not only is there a centralized project management office for both PPSs, but each hub within those PPSs are also going to have a project management office, and that's including people, particularly people like project managers, some data analysts, finance people, et cetera, that are going to be running the business, making sure we're compliant, making sure we're using funds appropriately, making sure we're contracting with providers appropriately, et cetera. But even more importantly, this is just pure project costs. So in order to implement a lot of these, you might need some capital money, you might need, you might need to hire staff, you need to train staff, all of this stuff, you might need to buy equipment, all of this stuff costs money, and DSRIP funds are available. I will mention also there is a separate stream of revenue available to the PPSs. It's over $1 billion for capital. It was done in a separate RFP process, and we did apply for a large amount of money that would be for IT needs and also for the co-location project, for the co-location of primary care with the emergency department. We will not find out if we receive any of that money, and also it is a match requirement, so it's about, they give us 50%, we match it about 50%, and we won't find out about that until October. So planning continues. We need to think about contingencies if we don't get that stream of money. Another really important use of DSRIP funding is for bonus and incentive payments for providers. So I mentioned earlier that we are going to be contracting with providers. We need providers to do the right thing, but there's a lot of work, hard work that needs to go into the DSRIP requirements in order to do the right thing, and a lot of these providers aren't just going to do it because we ask them to do it. We actually are going to contract with them. They'll have deliverables that they need to do, and if they meet those deliverables, then they will be incentivized through DSRIP funds. Another thing, especially for you hospital administrators out there that might be on your mind, is the fact that if we're supposed to reduce avoidable hospital use by 25% over the next 5 years, well, that means that we will undergo some revenue loss. And there is a fund, a percentage of the DSRIP funds that is set aside to support or to make up for that. And it's not going to continue past the 5 years. So the idea is you have it for now, but we are transforming to a more community-based ambulatory care setting, and we are intending to reduce our hospital footprint a little bit. So, but it is an important recognition from the state that the especially safety net hospitals will be needing to shore up their revenue while we undergo this transformation. And I will just say something very important that I failed to explain in the very beginning of this is that 95% of the funding for DSRIP is intended to go to safety net providers. So there's a lot of different ways where, for example, at CHS, we have multiple non-safety net hospitals. Mercy is a safety net hospital, and Good Samaritan is a safety net hospital, and our other 4 hospitals are not safety net. That doesn't mean that they won't be able to participate and get some of the funding if they're participating in DSRIP. But the bulk, the large lion's share of the money does go to safety net providers, whether it's hospitals or even PCPs, clinics, et cetera. And then we just have another a bucket for contingency funds, you know, rainy day. We don't know necessarily what's coming down the pike. This is truly an innovative program, and we just want to set some aside for the unexpected things that come up. Okay, so, you know, we've talked a lot. I mentioned in a couple of projects that we're leveraging ongoing activities. All is not lost. This is a daunting project and program, but there are a lot of things that are going on at our institutions currently that we can take advantage of and build off of and integrate DSRIP into, including ACO. Both St. John's and CHS have an interest in Beacon Health Partners, and now we have many physicians that are participating in the Accountable Care Organization, and a lot of population health programs are occurring within that program that we will leverage. We have, including practices becoming PCMHs. We have a large focus on care management workflows already. CHS is already up on the EPIC EHR, and we all pay attention through our especially in the world of Medicaid, we are all paying attention through the MCOs at HEDIS scores and other quality metrics of that nature. I think I probably made it clear. While we have a lot to leverage, we also have many challenges ahead of us. This data integration concept is very massive and very major. We hope to use the Rio and the Shinies to do a lot of this for us, but they're struggling as well as the concept of building a whole new infrastructure on our own to do data sharing. We have to do a lot of interfacing, and as I mentioned, the number of providers we have within our network that also have to get connected is it's a very heavy lift. We also have, particularly in the cardiac and the diabetes projects, which are in both PPSs, there's a high emphasis on the standardization of disease management protocols and guidelines. One thing that we've discovered is you go around to you ask a doctor if they follow XYZ guidelines, and they say sure. And then you actually go and observe them, and maybe they're doing steps 2 and 4 of 8, but not 1 through 8 comprehensively. Or maybe, they think they're doing it, but when you actually line it up to the guidelines, it's not happening. So really getting these, disseminating standards and protocols and guidelines to such a large network of providers is going to be a challenge. I've already mentioned the PCMH challenge. It's a very, very heavy lift. Everybody has to be connected to an EHR. That in itself is going to be a heavy lift. And then because of this wide network, we're talking all the way out on Long Island to Queens, and we need to somehow communicate with all of these providers, educate all of these providers, track all of these providers, do performance improvement activities with providers, and so it's very, very daunting to think about how wide scale these projects are going to be. So this is a little hard to see. I just wanted to talk a little bit, and sort of the names are fluid, and some of the staff positions aren't filled, as you'll see, but I did want to just talk a bit about how we're organizing the hubs. You'll see at the top there's sort of the PMO, some of the work stream components. We've got finance, we've got IT, we've got member engagement, provider engagement, et cetera, and we are assigning appropriate people to those activities. We will be adding some St. John's participants as well. And then I want to focus on the bottom half. We've tried to take the 15 projects and organize them into buckets. So we have like a hospital or a SNF-based project bucket, behavioral health bucket, and an ambulatory disease management bucket. We are just starting the process. It is the end of July, and we are just starting the process of hiring 3 project managers to organize activities around these projects. It is a way to not only bombard everyone, to avoid bombarding everyone with a lot of meetings and deliverables, et cetera, but also the advantages when you bring all these people with like-minded positions and expertise, and you bring them together, you can really get some great data sharing, best practice going, and we can really work collaboratively going forward. So the idea is, it says here July, it's going to be August. We're going to do a kickoff for these 3 teams, and then and we're going to take it from there. We hope to have a meeting about once a month. We might have some calls in between. We're going to go over, we're going to start brainstorming. We're going to talk about where we are today versus where we need to be tomorrow. We're going to start talking about all of the requirements involved for each of the projects. And then we'll probably get a little more granular and start planning on how to actually implement these projects at our local facilities and with our partners out in the community. So that concludes the DSRIP 101 presentation. I thank you for hanging in there for so long. Each of the PPSs does have a website. There's a wealth of resources. There's actually also a statewide DSRIP website. If you just Google New York DSRIP, you'll find it. I'm Jessica Wyman. I'm the Associate Director of DSRIP for Catholic Health Services of Long Island. I'm the second name in the hub contacts, and I would welcome any questions, feedback, concerns, etc. You can direct them to me. You can also email Robert Ginsberg, who's the Director of DSRIP, and Brendan Lambert, he's the DSRIP Coordinator. Those are your DSRIP, CHS Hub, DSRIP Project Management Office team members at this point in time, and we would welcome hearing from you about anything and everything DSRIP. Thank you so much for your time, and I look forward to hearing from you.